many international publications. He's also a recipient of Active Pediatrician Award in 2016 and is also a recipient of the Collector Award for his contribution in pediatrics. Over to you, sir. Dr. E. Siva Kumar. Sir will be talking about rational transfusion therapy for children.
Good evening to all. First of all, I would like to thank the organizers for giving me this opportunity to speak on this Puduvai Pedicon. The topic for the day is rational transfusion therapy for children. Next. So, transfusion was started way back, even before discovery of the blood group. In 1818, first documented transfusion was done by James Blundell, a British obstetrician, for a postpartum hemorrhage. Give transfusion for a postpartum hemorrhage, where the mother received the blood from his husband. Only long after that, only Karl Landsteiner discovered blood groups. Initially, he discovered A, B, and C. Later, the C was changed into O. So, he won the Nobel Prize in 1930. So, coming on to the functions of the blood, why we use blood transfusion? So, commonly we use to supplement oxygen. So, oxygen transport. In hypoxia, you usually give blood transfusion. Apart from that, there are many other functions for blood. It maintains oncotic pressure, removal of the metabolic end products, and also in key role in the defense mechanism. Also, it has a role in thermoregulation and nutrient transport. Coming on to the components of the blood. Whole blood is what we collect for 450 ml whole blood. It includes packed red blood cells, around 200 ml, and platelet-rich plasma, 250 ml. The platelet-rich plasma can be segregated to FFP, 200 ml, and platelet concentrate of 50 ml. Similarly, FFP is segregated into cryoprecipitate of 15 ml. So, one whole blood unit can be given for 4 recipients. So, RBC, platelet, FFP, and cryoprecipitate can be given. So, coming on to the whole blood, it is stored at a temperature of 2 to 6 degrees centigrade with a shelf life of 6 to 7 weeks. There is no functional platelets in a whole blood. So, it has a limited use only in the clinical setup. You have to go for ABO and RS compatibility before transfusion. The transfusion should be completed within 4 hours. There are few indications for whole blood nowadays. One is acute blood loss with the hypovolemic shock. When the blood loss is more than 20% of the blood volume. So 60 to 80 ml per kg in a child, if there is a more than 20% blood loss, approximately 15 ml per kg blood loss is suspected, you can go for whole blood transfusion. Apart from that, exchange transfusion, we use whole blood. Coming on to the packed red blood cells. So, around 150 to 200 ml of packed RBCs are present in a 1 unit of PRBC. It is the most commonly used blood product nowadays. You can use irradiated red blood cells if available. It is available only in few centers only to prevent the graft versus ghost disease. It is useful in lymphoma, stem cell transplant, and also in severe immunodeficiency disorders. Another thing is leuko-reduced red blood cells. It also reduces the risk of febrile reactions, CMV transmission, as well as alloimmunization. The facilities are not available. You can go for at least washed RBCs. With saline wash, you can use saline washed RBCs to reduce the reactions. Even if it is also not available, means you can just go for leukocyte filters. They are available in 1,000 rupees per pack, which can be used for children who require frequent transfusion, especially in thalassemia. So what are the indications for packed red blood cell transfusion? You have to maintain a hemoglobin of more than 12 gram. It means if the hemoglobin is less than 12 with a severe cardiac and pulmonary disease, it means the child is in severe hypoxia with the oxygen support with the FiO2 requirement more than 35%. And also if there is a requirement for ECMO, you can go for PRBC. For preoperatively, if the hemoglobin is less than 10 grams, you can go for PRBC. And postoperatively and symptomatic anemia, the cutoff is 7 grams per deciliter. For children more than 4 months, the cutoff is you can maintain hemoglobin more than 7 in the perioperative period and also in marrow failure. For thalassemia babies, the pre-transfusion hemoglobin can be maintained around 9 grams per deciliter. One thing you want to know is for severe iron deficiency anemia without any co-illness, transfusion can be avoided even it is less than 5 grams. So transfusion of 10 to 15 ml per kg will raise the hemoglobin by 2 to 3 gram per deciliter. It means the hematocrit is increased by 6 to 9%. Coming on to platelet concentrate. So single donor concentrate, single donor unit, it yields only 50 to 60 ml. What is a pooled unit means? You are getting from 4 to 6 donors. So the volume will be around 240 ml. It can be stored in a temperature of 20 to 24 degrees centigrade with gentle agitation, and it can be stored only for 3 to 5 days to avoid clumping. If it is not given gentle agitation, the platelet will be clumped and it will not be useful. So it must not be refrigerated before infusion. Platelet concentrates collected by platelet apheresis by a separated device. It can be used if you want to collect from a single donor. By single donor apheresis, you can collect around 150 to 300 ml. 1 unit of platelet concentrate per 10 kg raise the platelet count by 20 to 40 into 10 power 9 per deciliter. Again, it should be infused over a period of 30 minutes. It should be given quick. Coming on to the indications for platelet transfusion, for infants more than 4 months, maintain the platelet count more than 50 into 10 power 9 per liter with the bleeding manifestation. And also for major invasive procedure also, the count can be maintained more than 50. So if the count is less than 50 into 10 power 9, you have to go for transfusion. For minor procedures like LP and central line insertion, the count should be more than 25. So if the count is less than 25 into 10 power 9, you should avoid minor procedures. You can do it after platelet transfusion. Similarly, for marrow failure, the cutoff is 20 into 10 power 9 with hemorrhagic risk factors like sepsis, clotting abnormalities, and graft versus host disease. So without risk factors means the cutoff is 10 into 10 power 9. For newborn and infants less than 4 months, the cutoff is more than 100 into 10 power 9 with bleeding. For invasive procedure, for ibuprofen therapy and nitric acid therapy, it can be kept around 50 into 10 power 9. For clinically stable babies, no need for transfusion if it is more than 20 into 10 power 9. If it is less than 20 into 10 power 9, you have to go for transfusion. Coming on to fresh frozen plasma. It contains the plasma separated from whole blood within 6 hours of collection and rapidly frozen to minus 25 degrees centigrade or less. It is rich in clotting factors, about 70% of the normal factor 8 level, along with immunoglobulins and albumin. It has a shelf life of around 1 year. Before use, it should be thawed between 30 degrees centigrade to 37 degrees centigrade. And also it should be used within 6 hours of thawing. And the transfusion also here should be completed within 30 minutes. So coming on to the indications, commonly we use for hemorrhagic disease of the newborn, liver disease, acute liver cell failure and chronic decompensated liver disease, vitamin K deficiency, warfarin overdose, deficiency of antithrombin 3, deficiency of protein C and protein S. Whenever there is a massive transfusion with the packed cells, you have to supplement with the FFP also, especially for a blood loss, of severe blood loss. And also for plasmapheresis, the conditions requiring plasmapheresis like Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, thrombotic thrombocytopenic purpura, we need FFP. And least we use nowadays for hemophilia and A, because many times factors are available. If suppose it is not available, means only rarely only we are using FFP for hemophilia A and B. The dose is 10 to 20 ml per kg, and it should be used within 6 hours, and the transfusion should be completed within 30 minutes. Coming on to cryoprecipitate, it is prepared from the fresh frozen plasma by collecting the precipitate formed during the controlled thawing at 4 degrees centigrade and resuspending it in 10 to 20 ml of plasma. It is rich in factor 8, factor 13, von Willebrand factor, and fibrinogen. So it has a shelf life of around 1 year, and no compatibility testing is needed. It is useful in afibrinogenemia, dysfibrinogenemia, hypofibrinogenemia, von Willebrand disease, and also specific factor 13 and 8 deficiency. Word about granulocyte transfusion is indicated in severe neutropenia with at risk for febrile neutropenia, in neutrophil count less than 0.5 into 10 power 9 per liter in childhood children, or the count is less than 3 into 10 power 9 per liter in neonates. Granulocytes should be transfused within 24 hours of collection, but current efficiency of granulocyte transfusion is not well supported by trials. This one is the more important one. So decision for the transfusion should not be based on the lab values alone. Many times there will be error in the electronic counters. So careful assessment of the child's clinical condition is very much important. You have to clinically assess the child before deciding on the transfusion. So blood component transfusion should be preferred over the whole blood. Again, use of crystalloids, colloids wherever necessary should be given, and desmopressin, especially for mild hemophilia, and erythropoietin, especially for chronic kidney disease, should be encouraged to avoid transfusion and blood component therapy. Why we are afraid of transfusion? There are many adverse effects. So immunological and non-immunological adverse effects are there. Common one is urticaria. It is a 1 in 100. Every 1 in 100 transfusion children will have urticaria due to the antibody to donor plasma proteins. The next one is fever non-hemolytic reaction due to antibody to the donor leukocyte antigen. Next one is anaphylaxis. It is due to antibody to the IgA in the donor plasma. Hemolysis can occur due to red cell mismatch incompatibility, and other two rare but important complications are transfusion associated with the acute lung injury due to donor antibody to leukocyte of the patient, and graft versus host disease due to the functional lymphocytes in the blood of the transfusion. Coming on to the non-immunological adverse effects, transfusion associated circulatory overload should be kept in mind, especially in whole blood transfusion. And bacterial contamination can occur if it is not stored properly. Other rare adverse effects include hypothermia, hyperkalemia, and hypocalcemia. This is the one which is we much are worried about. So disease transmission risk. So there is a risk of hepatitis B transmission in 2 to 5 persons per million transfusion. Similarly, hepatitis C virus, HIV, human T-cell lymphocytic virus, there is a risk for 1 per 2 million transfusions. Even last week also we had a case The mother was antenatal first trimester screening was HIV negative. Then the mother had a transfusion at the last trimester of pregnancy, and afterwards, after childbirth, when the child has failed to thrive, features of immunodeficiency, the baby had features of HIV and they have proved. So the mother had asked for compensation and the inquiry is going on. So we must avoid transfusions as far as possible. Other viral infections like CMV, cytomegalovirus, West Nile virus, syphilis, malaria, babesia, and many other infections, including Zika virus, can be transmitted. In an unconscious or anesthetized child, hypotension and bleeding may be the only signs of incompatible transfusion. So it should be kept in mind, especially if the child is in perioperative period. Signs and symptoms of severe hemolytic reactions may be occurring within few minutes, initial few minutes, and within 5 to 10 ml of transfusion. So close observation at the start of the transfusion is essential. What is autologous blood? It is nothing but collection and reinfusion of the patient's own blood. Even children with weight more than 30 kg and hemoglobin more than 11 gram are eligible for autologous blood transfusion. So the blood is collected 4 to 5 weeks before elective surgery and can be reused. The child can be supplemented with iron. It reduces the risk of transfusion-transmitted infections. So, World Blood Donors Day. So, Blood Donors Day is celebrated over the world every month, every year on June 14 to raise global awareness of the need for safe blood and blood products transfusion, and also critical contribution by the voluntary unpaid blood donors. In India, father of transfusion medicine is Dr. Jai Gopal Jolie. He is the one who started the Department of Transfusion Medicine in Sanjay Gandhi Institute of Medical Sciences in Lucknow, first in country way back in 1981. And on remembrance of him, the National Voluntary Blood Donation Day is celebrated every year on 1st October in India. So I take this opportunity to please donate blood once, at least twice a year. We can actually donate 3 times a year, but at least twice a year we can donate blood to save lives. Thank you. Thank you for the question.
Thank you, sir. The various gray areas of the rational transfusion therapy doubts is well explained by Dr. Sivakumar, sir. So I have one question. You have mentioned various infections. Whether it is needed to get consent before transfusion for all the patients, is it necessary, sir?
Yes, sir. The consent form, you should get the consent form. Especially the case I was talking about, we have taken consent form. So we must explain the need for transfusion and explain the pros and cons of the transfusion, and you should get a consent form from the patient attender before transfusion. Sir.
Thank you, sir. Any other questions from the audience? If
No other questions? Now
thank you, sir. Thank you, sir.
I now request the chairperson, Dr. Balamurugan sir, to hand over the memento to our speaker first, Dr. P. Selvan. R. Selvan. I now request Dr. Balamurugan sir to hand over the memento to Dr. E. Siva Kumar. May I request Dr. Balashankar Professor and HOD and Director of ICH Madurai to hand over the memento to our chairperson today, Dr. Balamurugan.